Okay. Hi, everyone.
Hello.
Day 3 of internship. Everyone has survived. You're all in this room, so that's a good sign. So it is my pleasure to introduce Dr. Subir Shah. Dr. Subir Shah is one of our cardiologists, and he's going to be teaching you guys about heart failure today.
Cool. Can this definitely working? This on? Cool. Okay. Awesome. Well, shoot. Is this? Oh, where is you're good. Well, I'm Dr. Shah. I'm one of the cardiologists here. Welcome to Loyola. Congratulations. That's awesome. Third day you said, right? That's exciting. Any Michigan State people at all? Oh, bummer. Huh? Oh, that's messed up. All right. Any U of M people? Oh man, okay. Maybe yeah. All right. Well, yeah, congratulations. Welcome to Loyola. It's definitely gonna be a great 3 years for you, 3 years here for you, and if maybe a lot more depending on fellowships and stuff like that. We always love having fresh new faces around here and lots of questions and things like that. We have 18 fellows, general fellows, cardiology fellows, and then a bunch of interventional and EP fellows as well. They're all supposed to be really, really nice, even at 4 a.m. If you ever have any questions or anything, definitely call them, ask them for help. We'll be talking about heart failure, but anything cardiology wise, things can get definitely scary at times. And when it comes to the heart, people always seem to freak out. We'll go through this and show you that it's not the hardest thing. It's just one organ like everything else. But if you ever have any questions, definitely, feel free to reach out to our call fellows and stuff like that. They're always there to lend a helping hand. And if anyone ever yells at you for calling them, call me and then I'll call them. And then we'll leave it at that. But we're going to be talking about heart failure today. Heart failure is a topic I could probably talk about for weeks on end, but we've got 1 hour. And this lecture is more geared towards what to do during rounds when you're on call, and when you're kind of, trying to diagnose it, doing your admissions, things like that. We're not really going to get into the outpatient management as much. This is more for the inpatient management when you get called, someone short of breath and stuff like that. We're going to kind of make this, you know what, I should have tested it out. Do you have Microsoft Word on this? If not, or notes or whatever, we'll go through it. Okay. All right. So definition. What the definition of heart failure? An intern answer: someone short of breath with fluid all over. Sounds pretty legit. Describes everything that you need to know and kind of figure it out. Guideline answer: disease process that results from any structural or functional impairment of ventricular filling or ejection of blood. That sounds way too wordy. One of the things that we talk about when we trying to diagnose heart failure is whenever someone's short of breath with a history of heart failure, it's going to kind of come into your mix. Is this CHF? Is this something else? There's a lot of different things we kind of go through to figure out, well, clues and tips of what can tell us if this is truly failure or something else. Distinction of kinds of heart failure. Do you guys know diastolic versus systolic? I'm guessing. So HFpEF, you'll see this HFpEF, heart failure with preserved ejection fraction, typically ejection fraction above 50%. This is actually the more common type of heart failure. We just don't see it as commonly in the hospital. Everyone wants to say systolic heart failure is a more common one. It's the more common one seen in the hospital, but it does not mean that we don't see HFpEF more in the clinics. And when they do come in, what happens with these HFpEF patients is sometimes we miss the idea that it could be heart failure because all we're doing is paying attention to the ejection fraction. Okay. And these are actually, you guys didn't have a code. Did you end up having a coding lecture, billing lecture at all with Dr. Ansari? Okay. So for that lecture, to avoid yourself a lot of queries that you're going to get, the term HFpEF and HFrEF is totally okay to use. It's a way to make it easier, not to type make it as wordy, but it's definitely something we use. There's something in the middle, 41 to 49%, and that's kind of debatable depending on if it's recovered. It's kind of in the interim area. We typically, for the most part, once it's below 50, a lot of us will just end up using systolic heart failure, and that kind of works. All right, the classification, there's the ACC and the New York functional classification. These are things that you'll see a lot of times in the notes, and this kind of helps in the sense, not necessarily the acute setting, but it kind of helps tell you where they are and how, how many risk factors they have. You go through the ACC-AHA, they're really looking at structural heart disease. Once you have structural heart disease without a history of heart failure, structural heart disease with current heart failure symptoms, so that's C. And then D is really the end stage heart failure patients. Big thing to know with this is once you go down this pathway, you can never go backwards. So once you get to C, you're pretty much at C or D. And you're going to typically see most of our hospital patients, by definition, will be in the C range. NYHA functional class, this one can go up and down depending on how you optimize them and how you treat them. One is asymptomatic. You pretty much won't see that much in the hospital as much. Two is they're having mild heart failure symptoms with moderate levels of exertion. Three is they're getting moderate symptoms with mild exertion. And stage 4 is symptomatic heart failure all the time. So these things, while it doesn't necessarily help you in the acute setting, it kind of gives you an idea of where they land and where they stand. You have someone typically are 3C patients, they're going to be symptomatic. You kind of have to go after, is this a new change in symptoms? And that's kind of the big thing that you want to know is that a lot of times we see patients with heart failure and they're going to be short of breath and you're going to be thinking it's failure. But you kind of also have to wonder, is this their baseline heart failure or is this an acute on chronic event that really requires you to figure out what you want to do diuresis wise? All right, so diagnosing it. So the intern answer is going to be chest x-ray, BMP, echo, ask the nurse what they think, call my senior resident, call a fellow, call anybody you can to get an idea of what's going on. And that's, when I was an intern, I ordered all this stuff like crazy and troponins like on every single patient of mine because I was just gung-ho about it. And it was totally, a lot of times would lead me down the wrong direction. We'll kind of get into it in the question. Guideline answer, there's no single diagnostic test for heart failure because it's truly a clinical based exam based off of history and physical. Okay. And this is something that's really important when we're on rounds. A lot of times we'll see patients that, have chest x-ray findings and elevated BMP, and everyone wants to give me a history and physical, kind of suggesting the fact of pneumonia or COPD. And then all of a sudden the BMP is elevated and the chest x-ray shows some pleural effusions, and everyone wants to kind of say heart failure. And don't let the labs change your diagnosis. Really, it's really off of history and physical. And in the clinic, we really see this a lot is that, we don't get chest x-rays and BMPs and labs on all of our patients in clinic, but we have to be able to diagnose CHF without this stuff. And that's kind of the goal for you guys to figure out when you're waiting, when you're seeing this patient, is to take that extra couple minutes and to really go through the history and physical of it all. All right, so that means it's kind of all on you to kind of figure out how to figure out if this is CHF or not. So you kind of want to go through a stepwise approach. You kind of want to look to give yourself clues and hints about who's going to get CHF and who's got the risk factor. So who gets it, which patients will get it, history, physical, labs. Then once you figured out it, then you want to know about therapy. You breathe, you take a little breather because it's going to take a little bit of time to start working. You document what you're thinking, why you're thinking it, and what you're going to do for. And that's really important. I always tell my fellows too, is that you really want to document what you're saying, not just necessarily legally and for the chart or whatever, but really so people know what your thought process was, especially if you're on in the middle of the night. If you think someone's overloaded and you call us, we're gonna be like, yeah, why do you think they're overloaded? And if they are, if you give a good enough rationale, we're like, yeah, diuresis. And if it was the wrong move, well, those clinical signs and symptoms you had, made sense of why you diuresis. There's times that I still will treat someone like CHF and the next day I'm like, oh, I can't swear, oh crap, that it's something else and we were wrong. And that's totally fine. Some of our CHFers here are very tough. Even for our fellows, even for our faculty, and we really need right heart caths to really tell us what's going on. And so it's something that, as easy as it is, as it sounds sometimes it's slam dunk. A lot of times it's crazy hard to figure out. And when those are the cases, you want to write it down, take your idea of what's going on, why you diuresis them. And then if you need help, you ask somebody for help. All right. So who gets it? So patients above the age of 40 have a 20% chance of developing heart failure. That's kind of crazy to think that a lot of our patients, 1 out of 5 patients in the hospital potentially could have heart failure. But the nice thing is you have a you have a 20% chance of getting the diagnosis right and, saving the patient. So that's good. African American men have the highest prevalence. The easier thing is patients with a heart failure diagnosis and a recent readmission or recent admission with CHF. You're starting to get in the slam dunk range of saying this patient's probably got CHF if they're coming back in with shortness of breath. By the way, if anyone's got questions or anything, just feel free to raise your hand and ask it. It's supposed to be pretty informal. CHF actually has a 25% readmission rate nationwide in the first 30 days. There's a huge push to really go after this. But to tell you that someone gets diagnosed and discharged with CHF, you see them in the clinic, in the hospital again for shortness of breath, there's a really, really high chance of thinking that this patient's going to have CHF again. Same way is that someone just had recently CHF, they come in for something different. We forget that the CHF diagnosis is still lingering. And what we tell our fellows is if someone comes in with CHF for the first 30 days, think about that patient still actively having heart failure. Oops. All right. So who gets it? Heart failure risk factors. Patients with high blood pressure, 50% of patients admitted with heart failure will have a blood pressure above 140/90. And that makes sense when you think about the hypertension is causing the CHF because you got increased afterload and the heart has to pump out through the high blood pressure. And when you have a sick heart, it can't, and it backflows into the lungs, causing the shortness of breath. Diabetics, patients with ASCVD, metabolic syndrome, remember abdominal adiposity, hypertriglyceridemia, low HDL, hypertension, diabetes. Those are all big things that will put them at risk for CHF. Another one is this OSA that we always tend to forget about. When you have patients with OSA, it's really important to ask them, are they compliant with their CPAP? A lot of patients that go on a trip, they don't take their CPAP because they don't want to, they come back in short of breath. And a lot of this has to deal with them just not wearing their CPAP at night. Medication noncompliance or decreased effect is the other big thing. It's part of the things that we go through. We're going to go through history and physicals, trying to figure out what your slam dunk questions are, slam dunk clues are to really tell you this is CHF. And that's something that you want to kind of go through. And medication noncompliance is obviously huge. If someone's supposed to be taking furosemide or Lasix or Bumex, remember that's a diuretic. It's supposed to take off the fluid. If they're not taking the medication or the medication is no longer working, that means the fluid is staying on. There's a high likelihood that they're going to develop CHF. And so that's always a question that we still ask. Is one of my number one questions when I go down in the ER and we're with the fellow for consults or whatever, and we're saying, hey, are you on Lasix? Yes or no? Yes. Have you been taking it? Yes or no? And they're saying yes. I'm like, are you still urinating with that Lasix? Typical diuretic effect will take about 1 to 2 hours to work. If someone says, they're taking their Lasix and now it's taking them 3-4 hours of diurese, then that's a problem that you're saying, it might not be effective. On the flip side, if someone says, yeah, I've been taking my Lasix and I've been diuresing like crazy, I go to the bathrooms, that hasn't changed one bit, that's a marker to tell you maybe there's something else going on other than CHF. Cool. All right. Subgroups of heart failure. Patients with ACS will have it. Patients with accelerated hypertension, patients with obviously acute decompensated heart failure, patients with shock, worsening right heart failure. We'll get into this really briefly. And then patients after surgery are the big things that you're also going to see, because during surgery, a lot of patients, get their diuretics get held and they get a lot of volume during it. And at that point, they develop CHF. So you'll see a lot of the post-operative, and we get a lot of consults for it, is that post-operatively, what's going on, they're getting short of breath, is this heart failure. And it's because they typically got their diuretics got held and they got nailed with fluids for other obvious reasons. Okay. Any questions so far? Cool. All right. Common factors that precipitate decompensated heart failure. Non-adherence to meds is what you talked about, what we already talked about. Sodium is a huge one. 2-gram sodium restriction diet is what our patients are supposed to do. For questions or for interesting sake, what do you guys think of? What are some high foods in sodium? Soup is a big one. Great. Big I like it. Okay. What Big Macs? So frozen foods are big. Actually canned foods are actually the bigger offender. So a lot of times with our people that can't do fresh food always, we tell them actually to do more frozen foods and then the canned foods. The canned foods are a lot worse. What else? Soda is good, yeah. It's got a lot of fluid too. We talk about 2-liter fluid restriction. That's another big one. You'd be surprised. I do not drink a lot of water. I drink way too much coffee, like a lot of people probably. But there are patients that drink a ton of water. We've had patients that drink 5 to 6 liters of water per day. And those are ones that are obviously going to develop heart failure as well. What else? What other foods? That's a lot. That's good. I like it though. Okay. Seniors, what about you guys? The Chiefs? What else do you guys tell your patients not to avoid? Everything. Yeah, sauces, hot sauces, salad dressings. Those are all things that we actually don't really think about as much that have it in there. Big things is outside of foods, we talk about your NSAIDs, right? Those kind of medications will also increase sodium retention a lot. Steroids will start doing it a little bit as well for fluid retention. But there's a lot of different things that go into it. And it's really, a telltale when you figure out, well, why did someone come in CHF? If you're not sure if someone's CHF or not, and they're coming in, ask them what they just recently ate. You'd be surprised at how many people eat McDonald's while in the hospital. They somehow get it from a family member and they ate one and we didn't realize it. So it's always something big that the salt restriction, the fluid is a huge thing that can go into. We had a patient at CCU actually that we had to zip tie the faucets because he kept drinking water from the faucet, which is crazy to me, but he was drinking 8-9 liters a day without telling anybody. So it's always something that you really got to go into the history with. Sounds crazy. And we got super pissed every single day, but that's what he was doing. Really? He's back? Great. It's amazing. So, oh man. Uncorrected high blood pressure is a huge one. We don't think about it, but something that they are taking their meds and ask them what medications were they on at home and what was their blood pressure in the hospital. It's worthwhile when someone's crashing on you, look at their blood pressures for the last 24 hours. If they're significantly elevated all of a sudden, that could easily cause someone to flash and have pulmonary edema all of a sudden, causing the shortness of breath. Recent addition of negative inotropes is a big one. For diltiazem and beta blockers. I'm a cardiologist. Beta blockers are my favorite drug in the world. If I could take it every day, like put in a vitamin, I probably would. Saying that, when you add a beta blocker onto somebody in the acute setting, they might actually develop CHF. So while we think we did a proper thing, we could cause overload. This is really important when someone's in shock. If someone's in shock and they had a STEMI, a lot of times everyone wants to put beta blockers on automatically, and it's something that we have to think about not necessarily adding right away, because if they're still in shock, the negative inotropia is going to cause other problems. Okay. Excessive alcohol or drug use, concurrent infections, and then endocrine abnormalities, hypothyroid can both cause it. Everyone always thinks it's more hyperthyroid, but hypothyroid, we've definitely seen it can cause it as well. All right. So factors that precipitate it, we kind of went through a lot of this already. Yeah. Oh, the big one is AFib and other arrhythmias. You got a question?
No, it's just about the beta blocker. So let's say someone is already on a beta blocker, but you increase it. That is not that wouldn't have the same effect.
It shouldn't. I mean, it technically could. I've never seen it. If they're already on a beta blocker and you've upped their meds, I don't think it will, but theoretically it could. But typically they're already on it, and we always do it. Now, if someone's in shock, the big thing is you don't want to mess with their optimization of medical therapy. You want to mess with get their diuretics off, get the fluid off, and then go from there. But theoretically, it could cause it. I've never seen it though, so that helps. Did I miss this? Oh yeah, never mind. Simple things to look for. So immediate risk, these are the big things that when you're thinking about, really quickly. AFib and other arrhythmias. Whenever someone develops any kind of atrial arrhythmias, ventricular arrhythmias for that matter, the heart's not functioning properly. And because of that, you will start developing CHF. We'll ask Matt, since he's our cardio superstar. Why does AFib can cause heart failure? That's one. So yeah, the cardiomyopathy can develop. What else? Okay, good. Number 2. Yeah, good. So the no atrial kick is the big part. You know, when go back to med school, you get an atrial kick every single time. And in AFib, you lose that atrial kick. And when you talk about diastolic dysfunction, what's very interesting is patients with bad heart disease that have no history at all, or patients with bad heart history, you know, they don't rely on the atrial kick anymore because the diastology is so kind of progressed. But our normal, healthy 70, 80-year-old patients that are progressing, that are very healthy, that did all the right things in life, and all of a sudden develop AFib, well, when they lose that atrial kick, they're a lot more reliant on it than the normal person, and they develop heart failure like right away. If someone with AFib comes in short of breath, despite the tachyarrhythmia, the tachycardia, you can almost bet if you're not sure if it's CHF and they're short of breath, you can pretty much guarantee that they're going to be in CHF, because the AFib, when they go into AFib, they lose that atrial kick acutely, and they rely on it so much that they develop heart failure kind of right away. So if you ever see in the hospital and at night someone's developed AFib and they're short of breath all of a sudden, you can kind of bet you can put in the top of your differential that heart failure is probably going to be in that case. All right, so this is kind of things I kind of like to look for in the sense of you got immediate, intermediate, and low risk. This is kind of how you have to, when you see these signs and symptoms, you kind of want to have to think like, shoot, I got to react right away. Maybe call your senior right away or the fellow to be like, I think something's going on. So hypoxia, shock, hypoperfusion, respiratory distress, not making urine anymore. Obviously, acute worsening conditions will all start making you think, I got to treat the CHF right away, because if the system's going down, the heart's going down with it, you're gonna soon run out of time and you got to act pretty quickly. Intermediate risk, your new onset heart failure, low blood pressure without shock or perfusion. What does that mean when we say don't without the lactate, because you're going to order the lactate, it'll take 3 hours to get, so you can't rely on that just yet. What's the low blood pressure without shock or hyperperfusion? How do you assess that? So what on physical exam is going to tell you that they're not in shock? Good. Okay. What else? Capillary refill is another good one. Mental status changes, urination are all other good ones too. You know, what's really interesting about low blood pressure without shock or hyperperfusion is that when we see low blood pressure, everyone kind of freaks out and thinks it's cardiogenic shock. People will cancel the procedures, people will get really worried, and it's definitely something. But remember, a lot of our heart failure patients, especially our systolic ones with EFs of 15, 20%, they can't generate 120 over 80. They're going to generate, their blood pressures are 90s over 60s at baseline. And so even though it's low blood pressure, it might not be low for them. And this gets really important in the ICU setting when you have someone on pressors and you're putting them on pressors, you're trying to get them off of it from sepsis, and all of a sudden you can't get their MAPS above 65, and they've got an E of 15%, and they call cardiology to say, hey, is this patient in cardiogenic shock? And we're like, well, looking at their clinic visits and everything, their blood pressures are baseline low. This is their baseline, just stop the pressors. And it's something very important that a lot of our heart failure patients will have low BPs at baseline. Kidney dysfunction, hyponatremia, elevated. Hyponatremia is another good lab marker to tell you that, you know, if someone's got a low sodium, and they're short of breath and they've got a history of heart failure, you can pretty much bet that there's going to be some need for diuretics there. Elevated cardiac tropes, degree of BNP elevation is a huge one. In the clinic, a lot of times we'll get, you know, when we get a normal BNP, we'll get a BNP with it when they're stable heart failure, because a lot of these patients will have an elevated BNP. It might be 1,000, and they come in short of breath, and now it's 10,000. Well, that's significant. That's going to tell me, yeah, shoot, this is probably more CHF. Where if it went from 1,000 to 900, I'm going to be like, yep, it's elevated, but does it meet my criteria for saying this is CHF or something else? Okay. The lower risk are the ones with the normal blood pressure and heart rate, brisk response to the initial IV diuretic, which we'll talk about, rapid resolution of symptoms in the ED. A lot of times, the ER interns are they with us too? Oh, cool. Okay. So yeah, in the ER, what happens a lot of times, unfortunately, is that you'll see it, you'll diurese them, and they'll respond really well. And then a resident will come in and, you know, you're admitting them for CHF and they're no longer overloaded. And people are going to say, what the hell did the ER do? And this isn't right. This isn't CHF, but it was, and you just treated them really fast. And a lot of our patients, they flash on us really quickly, and just as quick as they flash, they diurese and they get better right away. And so you definitely see that just because they look totally fine doesn't mean they're in CHF. A lot of times the treatment starts and they did IREs 500 cc's and that was enough to get them out of failure. Yep, cool. Okay, so how do you diagnose it? It's all about the history. So let's kind of figure out as a group. I won't do the Word document. We'll just kind of talk about it in a sense of what on history. We kind of went through a bunch of stuff, but as a team, we got to figure out how can we diagnose CHF. So what in the history alone will tell you that it's congestive heart failure? There's at least like 20 different things we could say. Orthopnea, that's a good one. Huh? Okay, good. PND. Okay, good. Pedal edema. So that's a great one. But we're using the right context. Unfortunately, a lot of times pedal edema will throw everybody off. They don't look like CHF. There's something else, but they've got the chronic pedal edema, and that's a big issue, and that throws everybody off. But on service, when we see CHF, what I always tell the residents is you got to be able to diagnose CHF without telling me about lower extremity edema. Because unfortunately, a lot of our patients will have lower extremity edema from baseline low albumin, chronic venous insufficiency, or chronic heart failure. So it's not necessarily the pedal edema, it's the degree and the amount of pedal edema that's worsened. If the patients say, yeah, my legs look a lot worse, that helps. So a lot of times you ask them, do your legs look a lot more swollen than it was, or is this the normal baseline? If it's a normal baseline, then it kind of helps tell you something else. But the pedal edema should not be is a good thing, but it can't be the only thing that you're looking at. What else? What meds are they on? What else you say? Cool. Okay. Distended neck vein is tough because you ask a patient about distended neck veins, they'll be like, I have no idea. So more in physical, I like it. We'll get to physical in a second. What kind of cough? Cool. Like it. No, but that's a good one. What else? What? Who's a cardiologist? Dr. Shah did a shitty job, you know? It's kind of how it goes. Diuretics, right? We talk about diuretic resistance. Was the diuretic no longer working? A lot of our patients, the last couple of weeks, the diuretic slowly stopped working, and that's my sign. What did they just eat the last couple of days? Were they traveling? Did they eat a high salt diet? Are they drinking a lot of water? Did they take their NSAIDs? Are they on steroids? Are they starting to feel palpitations? Did they develop AFib all of a sudden? Seniors, what are your slam dunk ones? Hina? Weight gain, okay. Seth? Oh man, I like that one. That's good. Magda? Okay, good. Yeah, decreased exercise tolerance is a big one. The weight gain's another good one. What kind of weight gain are we looking at? 1 pound, 10 pounds, 20 pounds? More than 2 pounds? Damn. After lumen eyes, I might be in CHF. Damn. So typically we say about 5 pound weight gain over a couple of days. If you see like a 3 to 5 pound weight, I'll say 2 to 5 since Magda said 2. 2 to 5 pound weight gain in a couple of days, that's an issue. And that's a good sign of saying, do they need another diuretic? Those are all really good ones. So one of the big ones that I really like using is they have a decreased appetite. They get full a lot faster, early satiety. Most of us love to eat. And so when patients are gaining weight and getting full faster, that's telling me that they're probably got some gut edema. And when they've got edema, the next question I ask is, are the diuretics not working for you recently? Because typically once they get the gut edema, then the PO diuretics don't really work. So if they're saying weight gain, I'm like, are you getting hungry? Are you getting full faster? They say yes. You're not eating as much? Yes. How are your diuretics working? Not great. It's kind of almost slam dunk for me to say that's going to be CHF. And those are big kinds of things that you want to think about. Okay. So anorexia, weight loss, or why did I say weight loss? Weight gain? That's wrong. Rapid weight gain, palpitation, syncope, ICD shocks, if they had the peripheral edema, ascites, PND, orthopnea. Prior hospitalizations are always a big one. High sodium diet, and then adherence to medications. Those are all kind of your slam dunk ones that you want to think about when you're ordering. Physical exam. What on physical exam tells us that they're in CHF? Who said JVD? How do we check for JVD? I love it.
Okay, you recline them backwards. But measure like, I think it's like 3 centimeters above this.
So where are you looking? Let's make it really simple. Like up here, down here. You can pick on somebody too if you want help. It's cool. Okay, right side around the neck. Okay, good. Okay. What are you looking for? Just okay, good. So jugular venous pulsations. I like it. How do we know the difference between jugular venous pulsations and carotid artery pulsation? Which one's collapsible? Good. Okay, so that's really good. A lot of people don't answer that. So what you do is when you see JVD, if you say JVD up here, am I in video? This is good. Okay, I don't know if this will work. But you see JVD up here, you kind of press really lightly below it. And carotid, you won't be able to actually collapse and you'll still see the pulsation. Where JVD, you won't see it above it anymore. And you let go, the pulsation comes back. Now, if you hammer it down, then you might block the carotid. So don't go crazy, but just press really nice and like soft and gentle and see what happens. Okay. How does the pulsation look for JVD versus carotid? Yeah, so there's kind of like a double ripple, like with the JVD. With carotid, it's actually just fully pulsatile. Okay, going back to Matt again. What else can we tell the difference between JVD and carotid? What else can you do? What's Valsalva going to do? Kind of. It's a hard one to do. It's pretty hard to do because you're telling the patient Valsalva, they're moving a little bit. It's tough. You could do hepatojugular reflex, which I thought you were going to say. With hepatojugular reflex, the question is when you press, all of us will pulsate a little bit more. So it's the persistent rise of the JVD that sticks with it. But what else other than hepatojugular reflex can you do to tell if it's JVD versus carotid? So you lay them flat, you said, right? You bring them up. Arteries will not necessarily move in location. It'll be in the same spot where the veins will typically move a little bit. So if your pulsation moves a decent amount, then that's your JVD pulsation versus carotid typically should stay in the same spot. Now with our obese patients, it's very tough, but when you have a thin patient that's in heart failure, really take the time to really, try to see if that's there. So JVD is a great one, but it's a hard one. And the best time to see it is in the ER, to be honest, is when they're fully overloaded, that's when you want to really see the JVD take the minute. Okay. The joke always is with cardiology, the difference between a cardiologist and an internist is a cardiologist just shuts the door and listens with the stethoscope and like really looks at all that stuff because it just takes time. What else? Other than JVD? Pitting edema, good. Rails, Ronchi, good. What? Okay, ascites and gut edema, good. I like it. What else? S3 heart sound. I love it. How do we listen to the S3 heart sound? Either what? Well, sorry. Yeah. That was a dumb question. You're not going by the ear, so that's good. I like it. With the stethoscope, that's good. Yeah, good. So one of the things is with the bell, obviously the diaphragm bell. When you listen to the diaphragm, we're normally pressing down. When you listen to the bell, when I'm on the floor, I kind of just hold it there. I don't press down. The minute you press down, it turns into a diaphragm. For those of you that don't have the diaphragm and the bell, you just have one. The same kind of theory, you just let it sit there. You don't press down on it. Okay. Where do you listen for the S3? And if you say hard, I'm going to laugh. Where's that for everybody else? So you can definitely hear that there over times, and that's the other big one. Did you go to Loyola for med school, or did you go somewhere else? A lot of people don't use that Herbst Point anymore, so that's cool that you said it. I like it. A lot of, but if you really listen for S3, you're over here, and then you're at the apex, and it's hard when you're at the apex. You really want them laying down, kind of. If you're having them sitting up, you're gonna miss it. But the S3 is a very dull sound, and when they're in heart failure, you know, for me personally, it's one of the things when I'm not sure if someone's in CHF or not, and they're acute. The S3 always kind of guides me in the right direction. If I hear the S3, then I always diurese, and it always ends up working out. But it's a very hard murmur to hear. You kind of have to hallucinate it before you start hearing it for the first time. But it's something that can definitely help. So S3 is great. JVD is great. Pedal edema. What else? Okay. I like that's detailed. I love it. But that's a great one. You know, we always talk about orthopnea as a history, but you know, in the hospital, we definitely do that. The same thing we use as a physical exam is I lay them flat and I say, I'm going to come back in 5 minutes and see how you're doing. And a lot of times our acute CHFers will come right back up. And that's a big thing that you're going to see that you can create yourself. And it normally takes about 5-10 minutes, but you'll see by the time you come up, the patients are back up. So that's another big one. Cool. We talked about cool extremities as well if they're starting to go into shock. Right. I think you guys got the big ones. What about labs and tests? What labs and tests are you going to order to help tell you it's CHF? Okay, good BMP. That's going to be great. So, okay, good. Low sodium is definitely going to be something that helps point you in that direction. Okay, let's be honest. We'll all get the BUN creatinine for sure, right? We're all going to get it. It's fine. What's that going to tell you? Okay. The only problem you got to watch out with your BUN and creatinine are that you can also see that in our super dry patients as well, right? So when they're in shock, you're going to see it. When they're in heart failure, you're going to see it. They're over diuresed, you're going to see it. So it helps, or it could help, but it could also muddy the water. And you don't want to use that. If you see an AKI and they're in heart failure, you don't want, or they have a history of heart failure, you don't want to automatically think it's heart failure because to what you said, it could be over diuresis. What else? EKG. I love EKGs. So what about the EKG is going to tell you that they're in heart failure? Poor progression of R wave probably won't help. That kind of goes, that's an easy, that's a really big overcall in the EKG machines a lot. And depends on lead placement that goes with anterior wall MI. And if you're thinking, I mean, so you're looking for STEMIs on EKGs, that for sure will help tell you maybe someone's also in heart failure if they're having a STEMI and you'll diagnose a STEMI, which is kind of cool. But bundle branch block, okay. A new bundle that could be MI, but also if you're looking, you know, for not necessarily just AFib, but if they're having a lot of PVCs, PACs, you know, are they in flutter? Are they having ventricular arrhythmias and stuff like that? A bundle or heart blocks, all those things, it tells you what the heart's doing. They might not need AFib, but they might have a lot of extra beats and they're all PVCs, but those PVCs, especially with some of our sick heart patients, will cause CHF. What else? Bedside ultrasound. I love it. Okay. What in the bedside ultrasound are you going to help tell you CHF? Okay, good. What's one of the more common reasons you're going to see a nice fat IVC? That's not heart failure. That's tough. You could ask Matt right behind you. He's ready to go. So if you have severe tricuspid regurgitation, that's going to be a big thing. That's going to, a lot of times that kind of hurts us when we're looking at the IVC. And the easy way, if you can't do the bedside ultrasound, listen for systolic murmur of the tricuspid listening post, right? If you're a holosystolic murmur right around here, then you know that there's probably going to be severe TR, and the IVC now doesn't become as slam dunk. Okay. What else on labs tests you're going to order? We're going to order a ton of labs. What else are we going to order? Chest X-ray. What are we going to see on chest X-ray? I like it. Good. And you always want to compare it to the prior, obviously, right? Okay. Anything else? Echo. Okay. Yep. Kind of goes in with the fast echo. You can definitely, there's signs and symptoms there, or there's things on there that can help tell you. But echoes will tell you what kind of heart failure and why they're in heart failure. It necessarily won't tell you that they're in active heart failure. Anything else? So thyroid's always a big one. If they're in thyroid serum, we've seen them going to CHF. You know, what about troponins? Do you think a troponin's useful? Why is it useful? Okay, yeah, they can. And also the same wise, when they go into CHF, tropes are an easy way to say that the heart's working harder. And if you start seeing the tropes going up, that you got to kind of figure out why the trope is there. If you don't have a good reason for it and they're short of breath, it could be MI, but it also could just be bad CHF. Cool. All right. Right heart cath, left heart cath, obviously that goes into a little more detail. Good. Okay. So these are the framing criteria. That it was kind of a nice table if you kind of like the table format of kind of the things we kind of talked about just right now. Two major or one major, two minor. Knowing full. The one thing I really like about this is that if you see it, you see that bilateral ankle edema is in your minor criteria. And so that's why I always say you don't want to use that as your end all be all to help guide you. Take out lower extreme edema because it really is a minimal thing that can go into CHF. All right. This is another good chart. It's in the ESC guideline, the European guidelines, but it's just something that I always like going over. It's kind of the similar kind of thing that kind of look for. Do you guys do the B lines on lung ultrasound in your exams? You guys get taught that? Cool. It's something that's we don't do it as much in the US as much. We don't really, like our American, like ACC guidelines don't really go into this as much. It's cool that Europe does it and they put it in there, but it's just another thing that kind of helps tell you if it's CHF when you're kind of on the thing. Going back to BMP, who said BMP elevation? So what are other things that can cause an elevated BMP? So ACS can. Obesity will actually give you a reduced BMP. So when you have obese patients and you check the BMP, a low BMP won't really tell you anything because they just don't generate that BMP. One of the things on service that I do is a lot of times when people look at BMPs, I tell somebody to give me like 10 different reasons other than CHF that can cause a BMP elevation. And there's a lot of cardiac things that will cause it. And there's a lot of non-cardiac. Advancing age alone you'll start seeing an elevation, not in the thousands, but in the couple like 400 or 500 range, you'll start seeing that. Pulmonary hypertension, pneumonia, critical illness, like our septic patients will have it. Burns, chemotherapy patients will also develop it. So the BMP, while it's a useful lab test, there's a lot of other reasons that can cause an elevated BMP. All right. So, okay, last picture, and we're going to start getting in, or two more pictures and we'll get into therapy. So this is always the picture to know. How many of you guys have seen this before? Everybody? Some point? Okay. So it's kind of, if you're looking wet and dry and cold and wet. If you type that into Google, you'll get this every single time. It kind of tells you if they're in cardiogenic shock, if they're headed towards cardiogenic shock, kind of all the symptoms that we talked about and things that we already looked at and went over. But when you put that together, it's kind of a nice little pictorial that you can look at to kind of figure out where they are. When they are cold and wet, when they're in this range, this is where you're in trouble. This is where you have to start thinking about shock, okay? And then that's going into the types of shock that we see. You're gonna see a lot of hypovolemic, you're gonna see the cardiogenic, you're gonna see the septic. And these tables kind of go over, this is a little more detail than I wanna go into right now. But when you start seeing shock, what we always tell our fellows is, cardiogenic shock, it's kind of you gotta it's a pause before the act. It's a pause before the act of dying. And in that process, you really got to act quickly. And that's why for you guys, this is a really good pictorial to kind of go after that. You don't want to be guessing. And this is where, as much as you think you might know if they're in this window, you want to call somebody, because medicine may not be enough. It might be needing extra support or dobutamine or balloon pumps or something like that. When you start getting into this, when you're in warm and wet, you got time, you can think about it, you can hang out, you can kind of try what you want to try. But once you start getting into this phase, you got to start wondering what's going on, and you want to ask for help. Oh, PCW is your wedge pressure. And so that's your left atrial pressure. We get that off of right heart caths. Okay.
If there was something like, how would you tell if it was something like Tunnel syndrome versus, I guess if they were like a shock, they'd probably. Yeah, so if that's, do you just assume that they're like.
For what? For when they're in shock,
Yeah,
or
if they're cold and wet.
if they're cold and wet and they're showing you all these signs and symptoms of congestion and low perfusion, and you think they're in cardiogenic shock, then yeah, you want to diurese quickly. And we'll get into that in a second. A lot of times a lot of residents will say, even my fellows will still say that, yeah, they look dehydrated. They're, they look really dry, but they also look like they're in heart failure. And if someone that looks that looks dehydrated means hypoperfusing, but still looks overload, you're starting to tell me, are they in cardiogenic shock, or are we missing the boat on something else? Are they septic shock? Are they something else is going on? And so when someone's dry and wet at the same time, if that's what you're thinking, like they look dry, they look dehydrated, but they also look overloaded, then you kind of have to start wondering, is this truly cardiogenic shock, or is this something else and I'm just getting kind of jaded by the heart failure diagnosis? And we'll talk about treatment in a second. So treatment time, basically you got to get them to urinate, right? When someone's overloaded, you really got to start getting them to go. When you start doing diuretics, you want to obviously give IV. A lot of people will be efficient in the ER or on the floors when they're doing H&P, and they're going to have 10 of Lasix, 20 of Lasix IV. And you're like, if someone's coming overloaded, or you're seeing them in the middle of the night and they're crashing and they're looking like they're overloaded and they're starting to get in trouble, you want to nail them with a diuretic. You want to give like 1 to 2 times their total dose they were at home. Typically, honestly, if someone's Lasix naive, you can give 40 IV. If they're on Lasix or anything, you nail them with at least 80 IV to get them going. Okay. You really want them to start urinating. Now, going back to what you're saying with the creatinine, is that the creatinine, while it's, if it's the creatinine's 2.5, right? And their baseline's 1.4. Well, a lot of times people are like, well, the creatinine, there's an AKI. I don't want to injure the kidneys more. I'm just going to give 40 of Lasix, right? Because it's cardiorenal, it's whatever. I'm not sure. But I know it's heart failure, but I don't want to be wrong. I don't want to get yelled at. So I'll just give 40. The problem with giving only 40, giving a baby dose, if there's an AKI, you need to give them a bigger dose of diuretics. You need to get all their nephrons affected by the diuretic. And so that's when you give them like 80 or 120 IV. What I tell my residents and fellows in the CCU, if I'm in a CCU and someone comes in acute overload, I'm giving them like 120, 160 Lasix IV plus metolazone, and I'm like nailing them with a diuretic to get the fluid off, because you want to get that going right away. When I was an intern, I slow played it with the diuretic, and the patient didn't diurese, ended up getting intubated, and I felt like shit the next day. And it was a lesson I learned really quickly that, in the ER, you don't want to be like efficient in what kind of meds you want to use. You want to be effective and get the diuretics to work. And so if you think it's heart failure, if you went through everything we went through and came up with the diagnosis of CHF, you want to get the diuretics going. You want to give at least 40 or 80 IV to get the diuresis. Now, if they're not overloaded and you just dried them out, yeah, someone might come up to you the next day and be like, okay, let's talk about this and let's figure out why the diagnosis was wrong. But too many times what happens, even with my fellows, is that we'll slow play it and we got to get them going right away. And our bad heart failure patients that have a creatinines of 3, you're going to give them 80 or 120 and it's not going to work. They're not going to urinate at all. And that's like we're going to wait 12 hours. But in those 12 hours, if that patient was already looking like they're going to crash, you're going to crash pretty hard. And so you got to really reassess them. And the European guidelines have a really good algorithm for it of how aggressive they get. And for the seniors that know this, it's, the European guidelines from from minute they get in to 36 hours, that patient's on dialysis, so they're not making urine. That's really aggressive for what we do in the States, but that's how aggressive you can get. Not to say that we're going to do that here, but when you think someone's in CHF, diuresis is rule number one. Yeah, you're gonna ask something?
No, I'm just curious, like, how do you not, like, is there like a point of no return in terms of like, failure, like, in terms of how much you diuresis?
No, I mean, honestly, that's a good question. If someone's overloaded, like, yeah, nail them. I mean, you got to go. We've done Vumix strips, Lasix strips. I mean, with other medicines, there's metolazone and Diaril. So these are drugs that we're talking about. Lasix initial dose is 20 to 40 milligrams. But I mean, we have a lot of, when you're on card service, you're going to see these end stage heart failures that are going to go on dialysis potentially. We had a guy that we took 4 days to get him to finally open up. And then once he opened up, he diuresed 25 liters on us. But it took us 4 days to get there. We gave him everything we had, and he just finally started peeing for us. And that's great, but it took a while. But that's scary because those are the ones that we're really watching out for. If you give 20 or 40 or 80 of Lasix plus metolazone, they're not diuresing, it's going to be a hard time, and you're losing minutes or losing hours on trying to get the fluid off. And sometimes that's when we have to call renal and say, we need to do dialysis because I got to get the fluid off of them. But don't use the creatinine as a judge of saying, shoot, I don't want to diurese them because the creatinine's 4 and it used to be 2. If the creatinine is 4 because of heart failure, treat the heart failure. And that's the number one rule, is do not use, don't get scared by the creatinine, because if you get scared by the creatinine, you're going to baby dose it. And if you baby dose it, it's not going to work. And if you really think it's okay to say, shoot, the creatinine's 4. Are they really dry or are they really wet? Think about it and ask for help. If you're not sure, call your team and be like, I'm not sure if it's CHF or not, but I think it is. And that's what our fellows are there for too. I mean, they have the bedside ultrasound too. You guys can do them. I mean, there's a lot of different things, but when it's a creatinine of 3.5 and their normal is 1.8 or whatever, yeah, you don't want to be wrong. And we don't want to be wrong either, but you have to kind of trust your gut sometimes. And if you think it's CHF after everything we talked about, what you're going through, then trust your gut and give them a diuretic, but give them a hefty dose of it to make sure it works. That make sense? Kind of? Okay. Lasix is a great one that you'll see a lot. Bumex is another big one. If you're really thinking someone's crashing and you want the diuretic to work right away, you want to give them Bumex. So, because it can actually start working in like 5 minutes. Torsemide is another big one, which is another diuretic. Metolazone and Diaril. Metolazone is the booster pill. If you really try to get someone the fluid off, you give Lasix and metolazone, and they'll kind of work really good. I don't want to talk about that. Intravenous inotropic agents. This is when they're starting to go into cardiogenic shock. Dobutamine is going to be your initial thing that you want to use. Milrinone at your level will typically be done by the fellow, but dobutamine is a great inotrope. When you're someone, big rule of thumb for you guys is you see someone going into cardiogenic shock and they're hypoperfusing, they're not perfusing properly, they're wet. That's when you want to start asking your teams like, hey, is this patient going into shock? Is this something that we think about dobutamine and stuff like that? Okay. Maintenance meds we won't talk about as much. Basically, actually, big thing is, goal-directed medical therapy is great and I love it. But if someone, when you guys are on call in the middle of the night and someone is crashing and an overload, you don't worry about goal-directed medical therapy. All that stuff is to prevent heart failure from happening down the road. But in the acute phase, diuretics, inotropes, afterload reduction, lowering their blood pressure are all the big things that you're going to do. Remember, document it, what you're talking about, take credit in the chart. I always tell my fellows this: if you do something, take the credit. You do it bedside ultrasound, write down what you wrote. It takes a couple minutes. It doesn't have to be a long-winded, full progress note. You can just be like, patient short of breath, orthopnic, not banking urine, diuretics were held, gaining weight, we'll start diuretics. That's all you got to do. It's got to be a quick note so the next person coming on knows what you were thinking in the middle of the night when you saw it. Cool. Initial follow-up after, give the diuretic, go do your documentation, go see another sick patient, come back an hour or two later to see if the diuretic is working. Every 2 hours, you can evaluate this patient to see if they're diuresing. If they're not diuresing and you think they're in CHF, up the diuretic. You're totally allowed to if they're not making their urine and you think it's CHF. Every single time you do that, you do want to make sure that they're in actual CHF and you're not missing the diagnosis on something else. Place them on the right amount of oxygen. Always place them on the right amount of oxygen up to, like, you want them above 90%. You don't need them to be to 98%. The problem with putting them at 99% is when they need that 2 liters, you don't really catch it. If they're on room air and all of a sudden they need 1 liter or 2 liters, that's your indication that, shoot, something's going on. But if you have them on 2 liters at baseline and they're getting worse when they need that 2 liters, you're not necessarily going to notice it. Code stats discussion is always a big thing, just to know when they're in overload. You want to start knowing if this goes down the wrong direction. Are we going to intubate? Are we going to do whatever, CPR and stuff like that? Sorry, kind of went a little bit over, I think. I wanted to have a couple more minutes of questions, but any big questions on this? You guys are all heart failure gurus. Awesome. It's something that you're definitely going to see a lot of. It's, Loyola we have a lot of sick pathology here, and there's a lot of hard patients that we have a hard time with. So if you're not sure, that's when you can always call us. The big thing the fellows are going to want to know, they're going to ask you the questions, why do you think the patient's in heart failure? Your seniors are going to want to know that, and that's just good for you to learn and to go through the process yourself and just to take your time. If they're not encouraging shock, you've got time to breathe. They're not going to crash on you all of a sudden. Our patients with the low EF, 15%, they're coming in short of breath. They're on 5-6 liters of oxygen. You've got some time. Another big thing that you can do in the meantime is put them on a BiPAP. I know it's annoying because you got to move them to the CCUs or ICUs or whatever, but that does buy you some time if you need it. But it's something to take your time, write it down, go through it, and come up with a diagnosis. But it's not a quick thing. You got to figure it out in 2-3 minutes. You got an easy 5, 10, 20 minutes. Talk to the patient and spend the time, get the diagnosis from them, and it'll kind of help. But yeah, if you need anything, have any questions along the way, you see us along in the hallways, have questions, just let us know. We're always here to help. And yeah, congrats again and welcome to Loyola. Sorry, I accident.
I'm gonna bring the QR code back up.